Good morning, everyone. It's 10:05. We'll get started. We'll continue to let people in as they join. Welcome to the Fall 2024 Board of Governors series, jointly presented by Cal and Seoul. Whoops. My name is Ryan DeGive. I am the chair for Cal's Member Advancement Committee. Today with me, I have my fellow committee members, Rick and Grace, as well as our partner from the Seoul chapter, Mary. We all welcome you to this series. We look forward to spending the next 5 Saturdays with you and discussing FACHE and the Board of Governors exam. Our structure is a little bit different from some of the other series. We actually teach to the questions that you will see on the exam. So we will break down the 10 different knowledge areas, look at sample questions, and teach you a technique that Rick has developed to kind of look at the questions, break them down, break each answer down into true and false, and be able to kind of weed out answers that don't make sense. So our goal is to kind of prepare you for what you'll see on the exam and be able to work through those questions. Few housekeeping items. If you do have questions throughout the session, please feel free to raise your hand or utilize the meeting chat box. We have eyes on the chat box, so we're happy to, answer a question there, or if you would like to speak up, you can unmute yourself when we call on you, and we love to have the interaction, especially as we're going through the questions. We'll ask you to go ahead and put your thoughts in the comment box, and then if you have any thoughts or ideas afterwards that you want to explore a little bit more for the questions, please feel free to raise your hand and we can discuss them. So hopefully you all received the initial email the other day. We will send a pre-workout every week, usually Wednesday or Thursday prior to the session. This will include a link to some pre-recorded videos, as well as some slide decks and tip sheets for the knowledge domain that we will cover that week. We'll also send pre-session emails out, usually Monday or Tuesday, with the recorded session from Saturday, as well as any of the supplemental materials that we presented. So that'll be basically how our series works. As I said, we teach the questions. So each week, normally we'll cover 2 different knowledge areas, going through the supplemental questions that we have for them. We'll have guests come in that are experts in those areas that'll walk through the different knowledge areas and discuss their thoughts on the questions and how they would approach them. Today, we're just going to look at a brief overview of the application process and what qualifies you for eligibility for the FACHE. And then we're going to dive into our first knowledge area of healthcare. We have a special guest who will present that area, and I will introduce her in a little bit. So we'll get started on the actual FACHE application, eligibility, all of that. Most of you should be familiar with the My ACHE. On the ACHE websites, your ability to kind of fill in your profile, add your experience, your degrees, your education, as well as this is where you'll see any education that you've taken through ACHE, whether it's in person or interactive. They'll post it here as well. So requirements to sit for the ACHE Board of Governors exam in advance. So the first thing is you have to be a member of ACHE for at least 1 year. You do need to have an advanced degree, so master's, doctorate, other form of post-bachelorate degree. You need to have a current executive healthcare management position and a minimum of 5 years of healthcare management experience, which is a little subjective. So we do have a decision matrix that I'll show you in a second that can kind of help you break down your experience so that you know if you qualify or when you qualify. You also need to do some volunteer activities. So 4 activities within the last 3 years. 2 of those need to be civic community-based activities. 2 of those need to be healthcare related activities. We'll go into those in a second as well. So here's the decision matrix that I mentioned. This kind of allows you to put down your position, the time periods you were in that position, and break down the different tasks that you had to show that you have those experiences within healthcare leadership. So this is just an easy way. It's on the ACHE website, but it allows you to kind of look to see what experience you have and areas that you may need to focus on a little bit before you apply for your FACHE exam. One of the other things that is a requirement is continuing education. Even after you've achieved your fellowship, you need to continue to do the same thing every 3 years. So 36 continuing education hours. ACHE has kind of broken this down a little bit this year differently than they have in the past. They've added the 12 ACHE virtual interactive education hours as part of the requirement. So you need to have a minimum of 12 ACHE in-person education, 12 ACHE virtual education, and then there's the 12 qualifying education hours that you can get from different areas. This series will actually give you 8 of those qualifying education hours, which will, if you don't already have some, will add to your overall application. Qualifying education hours are self-reported, so you'll have to enter these into your ACHE profile. The nice thing about if you have more education in-person hours, those can fill in any gaps you have in interactive and qualifying education. And the same is true for the virtual interactive education. If you have more of those can kind of help cover some of the qualifying education hours. So going back to the volunteer activities that you need to do within the last 3 years. So 2 community-based civic events. These can be events that are one day or ongoing throughout the year. In the past, what I've done is the local communities do a community day of service. So I volunteer on those days to do the community-based service around my area. Not only benefits my community, but also helps with my application towards my fellowship. 2 healthcare related activities, you can attend health fairs, or if you're a member of your local chapter, if it's Cal, if it's Sol, if it's a different ACHE chapter, if you get involved in the chapter and volunteer, those volunteer years count as one healthcare activity. Two references are needed for your application. One of the references is actually a structured interview with a current fellow. This is where they will sit down with you either in person or through Zoom, Teams, whatever other virtual platform you utilize, and we'll actually go through some questions with you, get you to discuss your experience, your understanding of ACHE, and what it stands for, as well as, what your overall leadership style and leadership experience has been. They'll then document all of that, send it off to ACHE with the recommendation. The second reference can either be from a senior level executive at your organization or another current fellow. With this reference, basically you'll name that person in your application. They'll get sent a link where they'll fill out just a recommendation that ACHE sends them. So our advancement committee does have members that are willing to help with one or both of these that are fellows. So if you do not know a current fellow, or you don't know somebody who's in senior leadership at your organization, and you do need some assistance with that portion of the application, please feel free to reach out to us, and we will get you in touch with somebody. So the whole process itself, once you've gotten those first few things taken care of, you've gotten the 36 hours, you have your structured interview down, you have your person who's going to provide the other reference, you've done all 4 of your community-based and healthcare volunteering events, then you apply your application through my ACHE, you pay $250 fee. So once all of that goes through and it's been approved by ACHE, you should receive an authorization email. I'm not sure if they actually still send a letter out. They might, but I know mine came through email that authorizes you to go ahead and take the exam. That application and that ability to take the exam is valid for 2 years. So once you've applied, you have 2 years to then take the exam. Once you've registered for the exam, you have 30 days to take it. So once you've been approved to take the exam, you don't have to automatically just register for it. You have, 2 years to prepare. You don't need to take those full 2 years, but before you actually register to take the exam, make sure that you've prepared a little bit and you're ready to do it, because once you register, it is within 30 days. Within that 2-year application window that you have to take the fellowship exam, you can take the exam as many times as you want to. There is a 60-day waiting period in between attempts. So if you've taken it once, you didn't pass, you do have to wait 60 days before you can take it again. You do have to pay the exam fee each time you take it. But you do have unlimited times within that 2 years. So don't feel like you need to stress out that if you don't pass it the first time, you have other attempts that you can take. And it is administered by Pearson VUE, a computer-based testing system. You do have to go on site to a location of Pearson VUE. There's multiple throughout Northern California, Southern California, and even throughout the United States. Once you get your authorization letter, they should have a link for you to be able to look at Pearson VUE to see where you can take the exam. An alternative is you can actually take it. It's a paper-based exam at Cal or ACHE Congress. So that is one option you can do each year if you'd like to do it in person on paper. So this is the exam
Ryan?
outline. Yes.
I had a clarification just so I understand it. So the application fee is $250 and that's good for 2 years. But then when you're ready to register, that's another fee, and that's the countdown where you only have 30 days.
Yes.
So there's 2 parts to it, basically.
There's 2 separate fees. There's the application fee to be able to take it, and then there's the application fee to actually, sorry, there's the application fee to apply for it, then there's the application fee to actually take it.
Okay.
There are waivers for that test application fee, the $225, depending upon when you register to take it. Sometimes you pay that $225 fee, but ACHE will give you a free second test if you don't pass the first one, or they may waive the fee altogether. They do have certain times of the year, it's usually after Congress, where they allow you basically to take the test for free. And we do have.
If you pay,
go ahead.
Sorry. So if you take it and you register, and hopefully this doesn't happen, and you don't pass, then you wait 60 days and then you have to pay a second registration fee, because your application fee is still good for 2 years.
Yeah, your application fee is still good for 2 years. And then the registration fee to take the exam is $225 each time.
But our credits for volunteering and the CE units, we have to be mindful of that, right? Because that, I mean, how does that work?
So once you've applied, you've done that whole application to advance to fellow to be able to take the exam and paid that $250 fee, whatever was in your application, if it was 3 years back or not, is good for 2 more years. So within that 2 years, you don't have to do anything else technically for volunteering, for continuing education, any of that. You have that 2-year window where your application has been accepted, and you can take the exam to advance to fellow. So here's the outline and the 10 different knowledge areas that are covered on the exam. Again, we will be going over these different knowledge areas throughout the series. presenting various questions that you may see on the exam and how to walk through them. So I won't go into depth here, but we will touch on them with each knowledge area that we go through. So the exam itself is 230 questions. Only 200 of those are actually scored. What ACHE likes to do is they come up with new questions all the time to try and make it not so much challenging, but just to make sure that they're staying relevant with the questions that they're asking. So they do have 30 questions that are not scored that are just for them to see if they're ones that they should include in future test versions. So it measures your competence in not book learning. So basically what that means is your ability to apply the knowledge areas to everyday situations within healthcare leadership. So your ability to look at finance, look at IT, look at these different areas and apply them to the different tasks that you normally would within your normal role within healthcare. That doesn't mean that you shouldn't brush up on those areas and not look at what, different financial ratios. It's more of your ability to apply those areas to different scenarios. So some helpful resources that ACHE does offer on top of um, events like this is a fellowship concierge appointment, which is something new that they're offering, which I encourage all of you to do. It's a 15-minute appointment with a specialist at ACHE that kind of takes a look at what you've done so far towards your application and can kind of guide you on any areas you may be missing, what you need to do in order to have a full application packet that will most certainly be approved. So I highly encourage you to visit that website that's there and book an appointment. They do free quarterly live overviews. The next session is going to be in December of this year, where they kind of go over some of the things that I just went over a little bit more in depth, probably, just to kind of give you an idea of what to expect on your application process. So they do have some exam preparation resources. You can visit that website there. They do have some frequently FAQs that they post that also help with the application itself. One of the other things I do encourage you to do if you do have the time, I know it does overlap with our sessions, unfortunately, but ACHE does offer a virtual Board of Governors exam review course. Theirs is a little bit different. It does offer you 14 virtual interactive credits. So if you are short in that area, this will cover all of those credits, but they kind of go more in depth on the overall knowledge areas itself, touch a little bit on the test, touch a little bit on the application process. So it's a great resource as well. They offer an exam study set of books. They also offer flashcards, and then they offer them as a bundle set, which I'll show in a second. This is just a plug for our Cal Congress coming up. If you need ACHE in-person credits, you'll be able to receive 6 ACHE in-person credits for this event. I included the Eventbrite link on here, so if you get a chance and want to check it out, please go ahead and do so. So here are the actual books that I was talking about. If there's one in particular that I think you should get above all others, it's the Well-Managed Healthcare Organization. It kind of covers all of the knowledge areas in general. And if you're going to read one of the books, I would recommend that one. But they do come in a bundle with the Well-Managed Healthcare Organization, along with finance, information technology, and HR to give you a little bit more depth in those areas. And again, they do offer the bundle. They have the books themselves, the flashcards, which are very useful, and they do have digital flashcards. I would say the flashcards themselves, the booklet that they give you is really helpful. It helps you kind of look at different knowledge areas in a different way. It kind of helps you answer specific questions about topics. So I would recommend getting this. We do have some older versions of these books that we can lend out to those of you who have already registered for the exam. one of our committee members, Nora, has, I believe, 2 copies of the previous versions of these. So if you're interested, please let us know and we can connect you with Nora. So this is just a testimonial from one of our Cal members who recently took the exam within the past couple of years. Some of you may know Michael. This is just his recommendation for how to approach the exam and what helped him. He's also one of our members of the Wall of Fame, we like to call it. So everyone who's come through our Board of Governors series and then gone on to pass the exam, we're very proud to hear your story. We partner with our Cal Communications team to do a member spotlight each month on those of you who have successfully passed your exam and moved on to fellowship. So even after this, once you've taken your test, and passed it, we would love to hear from you. We would love to connect you with our communications team and do a spotlight. Before we move on to the first knowledge area, are there any additional questions regarding the fellowship application or any of the areas that I covered in there?
Ryan, can I throw something in?
Of course.
The resources he listed are really good, but each of us are different on what we know. So before you start buying books and devoting time to reading them, think about what you know already and what areas you really need to concentrate on. So just as an example, if in day-to-day life you very rarely deal with your board of governors or board of trustees, whatever you have, you may need to spend more time on governance. If you're like me and you try your best never to go near HR, you've got to find a way to study that more. But think about what areas you're strong in and then invest in the resources that are more directed to that. A well-managed healthcare organization is the broadest one, and that one I would recommend to everyone.
Thanks, Rick. Those are great points. And I think I skipped over that slide that mentioned that there are resources on ACHE where you can kind of break down where your knowledge gaps may be. They do have different resources there to help you walk through what you know and where you should kind of focus more on your overall preparation for. So it is in that slide deck as well. All right, Rick, I will turn it over to you and Lauren. I think you're on mute, Rick.
I was on mute. I'm going to introduce Lauren Murphy, who's going to be primarily leading us through the healthcare section. Lauren is one of my colleagues at California State University Chico in the Health Admin program, and she's actually one of our graduates of the program. Since then, she's gotten a master's, mainly focusing on public policy, and is currently working on her doctorate in health administration and is teaching part-time in our program. Her main job is working as a policy analyst at the California chapter of the American College of Healthcare Executives. And when she was a student, I told her that she should become a professor, and she laughed at me. So now I laugh back. All right, let's look at the first question. Let's look at the main areas. Lauren, you want to go over this, or?
Yeah, so as you'll see when we go through these slides, the healthcare area is incredibly broad. It would be impossible to cover all of these topics with you in a single Zoom meeting, let alone, I would argue, an 8-hour video. Even a semester of university is hard to get through all of the areas of healthcare. I can say in Chico's program, I'd say this is probably broken up into, 3 classes? Maybe 4? So broadly for this category, you're looking at healthcare terminology, some finance information about how we're paying physicians, what the healthcare continuum is, levels of service, what the different types of providers are, who the different types of providers are, and those support services that go with them. Then there's another slide. So they're going to ask things about how the different sections of healthcare work together, what different roles clinicians can play in the system, what different roles staff play in the system, how patients and providers view the system differently, how things interact with one another in terms of cost, quality, and access. I'm really speeding through these because, again, it's pretty hard to get through all of them, and I don't want to overburden you by trying.
Before we start in on the first question, I just want to say something about our approach here. My feeling is that people who are unsuccessful in taking the test, this test or any other test, they probably knew the material, and where they fall apart or where they fall down is on their test taking technique. And that's why we're going to try to walk you through a process for answering the questions more than the content, right? In 8 hours of this program, there's absolutely no way that we can teach you the content. We're not even going to try. You're on your own for that with our guidance. So we've given you those videos that are summaries of the areas, but you need to find which ones work for you and which ones you need to study for more. But we're going to concentrate on how do you address the question, right? So when you look at a question, there's a tendency to want to panic and start rushing through things. And the one thing I would like to stress more than anything else is slow down, right? You've got 6 hours to take this test. If you take 6 hours, I don't know what you're doing for most of the time, okay? You don't need that much time. So you are in absolutely no hurry at all. Fight off your urge to panic, right? And that means that instead of just jumping in and putting down an answer, you've got the time to really look at the question and figure out what is it asking and then pick the answer. So what you want to do when you first look at that question, improving profit for a health services network that contracts with employers on a capitated basis, but pay providers on a fee-for-service basis. God, it seems like there's some words missing from there. What are you asking for? What's the knowledge area here? Well, I think that what you want to narrow it down to, and there's a lot of words there, even the ones that are there, there's a lot of them. I think it's looking at how are organizations paid, right? The words that are jumping off the screen to me are capitated basis, fee-for-service basis. So I know that when I'm looking for the right answer, it's going to be something related to how do those work, right? Now, when you read the question, get rid of the words that, that don't add value to you. Look for the keywords that are going to point you towards the right area, but don't read it really fast. And some people have even said, read it backwards. By possible, basis, service, for. Why would you do that? Because you're more likely to not glide over keywords like never, always, not, else, things like that, that may actually turn your question around, right? When you read over it, your eyes and your brain are moving quickly. I think your brain is going faster than your eyes sometimes. You jump ahead, you interpret the question before you finish reading it. Slow yourself down. Then you've got 4 choices there. And one of these is right and 3 are wrong, ideally. But sometimes 2 of them are right, and you have to figure out which one is more right. So go back to the wording of the question. Are they saying which is the most? Which is the highest number? Which is the trend? That may tell you, okay, I've got 2 answers here that could be right, but one of them is going to be more right than others. They call the wrong answers distractors, and that's a really good description because they're trying to distract you from the right answer. A good multiple choice question has feasible answers. All of them, when you look at it, look like they're feasible. So you've got to get past the distraction to find the right one. The best way I think to do this is say, instead of having a multiple choice that gives you a choice of 4 answers and you have to pick one, treat them like you have 4 true false answers, right? True false. So I know I'm looking for how to improve profit when the employers are paying capitated and the providers are paid fee for service. I'm looking for that. And I'm going to ask myself with each one of these, is this true or false? So if I'm paying providers on a fee for service basis, can I improve profits by increasing the number of inpatient procedures? Lauren, can I?
You cannot.
Why
You
can't I?
a flat rate from capitation, but you're paying your provider's fee for service. So if you're increasing the number of procedures, you're receiving the same amount of money, but you're sending more out to your providers.
Not
So
a way to improve profit.
The opposite of improving profit, in fact.
Okay. Well, what about number 2, reducing per member per month rates to employers? So per member per month is basically capitation, right? You get a flat amount coming in. And what if you reduce how much money is coming in? Will that increase your profit? You're shaking your head.
Again, we are doing the opposite of increasing profit. We are reducing the amount of money that we have in our bank accounts, but the amount that we're sending out, it arguably is remaining the same. So the amount we have left over, our profit would be lower.
Okay, so A is false and B is false. Let's look at C. Increasing the payment rates to network hospitals.
I feel like anything that involves increasing payment rates is probably not going to increase our profits.
Okay, because under capitation, our revenue is capped, right? It's not going to go up or down. Revenue is capped. And if we're paying more money out, I'm not an accountant, but I'm pretty sure that means less profit. Okay. So we've got false, false, false. Ideally, D is going to be true, right? Before I've read it, I'm pretty sure D is going to be true, but I'm going to read it anyway because I might have messed up. It's going to happen. So reducing utilization. All right. So what will you reducing my utilization do?
That will increase our profits because we are paying our providers on fee for service. So if they're providing less services, we are paying them less money, hence we will have higher profits.
So again, with the amount of money coming in, it's capped, but I can send less money out. That means I get to keep more money. So I'm going to go back and review the question. Improving profit, paid on capitated basis, pay providers fee for service. I've got false, 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 and D is true. If I reduce utilization of services, then I'm going to improve my profit. So I'm going to say the answer is D. Is it, Ryan?
It is D.
Woo!
Wow. Now, I got to tell you, I didn't look at these questions beforehand. So at least once, I'm going to, every week, I'm going to mess up something. Just is. You don't have to get 100%. That's a good thing. We don't know what the pass rate is, but it's somewhere less than 100%. You don't have to get 100. It's okay to mess things up, and you're going to do that, but you try not to. So what Lauren and I just did was what we call a brain walk, right? We let you into our brains, which is a really scary place, but we wanted to show you, and we're going to continue to show you, the way that you can look at a question, analyze it, break down the question, and then look at each of the options to see which of the 4 is going to be true and which of the 3 are false. So why don't we go to number 2, and I'll let Lauren take that one.
So number 2 has less words, which can be a pro or can be a con. There's less hints in the question about, there's less specifics about specific payment type. It's just which of the following is true about a capitated managed care organization arrangement. So this one, to me, I don't always love these types of questions on standardized tests because the answer could be totally different things. It could focus on, I'm guessing it's going to focus on finance because it specifically mentions capitated payment, but there's no guarantee. It could ask about utilization. It could ask about any number of things. So I have to look at my answers to try and weigh which direction I think this is going to go. So option A is the provider shifts financial risk to the managed care organization. And my gut reaction for answer A is to say that that would be false. I know that managed care organizations came around in response to the financial risk being on the payer versus the provider. So I feel like that's false. It's actually the opposite. Capitated managed care often shifts risk to the provider instead of the payer. So to me, A is false. B, the provider can bill separately for each service provided. Well, as Rick mentioned with question A, capitated payment tends to be per member per month. It's not necessarily separate itemized bills. So I'm going to say B is false. C, the provider must wait to bill the managed care organization until services have been provided to a patient. Once again, if we remember that capitation is per member per month, the provider is getting paid in advance for services provided in a given month. So that seems false to me. And then D, the provider is paid a set fee. Well, per member per month would be a set fee based on how many members you're seeing. So I would say that D is correct. And if we look back at the question, is this true about capitated managed care organizations? The provider is paid a set fee, seems right to me. So I'm going to say the answer is D again.
You are correct.
So this may seem like it's a really slow process, that you're spending a lot of time on questions, and it probably is, and that's okay. All right. If you rushed, you may have scanned over and you may have said, yeah, I know about managed care. I know about capitation. Fine, I can just do this quickly. And sometimes you can, sometimes you can't. But doing it this way, forcing yourself to really look at the question, to really look at each of the options, treat them as true, false, is going to increase the number of correct answers that you give. It's going to increase your odds of passing the test the first time, or for some of you taking it the second time. This is not giving you information, right? You need to know about capitation, need to know about managed care when you go in, but it's going to give you a way to systematically apply what you know to the question and hopefully get the right answer.
See, talking through it like this, I feel like makes it take longer. Doing it in my head is a lot faster than, speaking through it and explaining my thought process to everyone. And the more you practice this style of test taking, the faster you get at.
It is a practice thing. That's a good point. All right, let's go to number 3. Which of the following is not one of the reasons that HMOs and PPOs have lost traction in cost containment in recent years? Right now, this is an example of why you want to read the question carefully, because if I just look at it and say, which of the following is the reason that, I'm going to get it backwards. So looking at each word, maybe going backwards, years, recent, in, containment, cost, in, traction, lost, have, PPO, I'm more likely to find those words, right? And again, it feels like it's taking time. You got plenty of time, but you want to make sure you're getting those words that really flip your answer. So what I'm looking at, again, back to managed care, HMOs, PPOs, and I'm looking for them not doing as well in cost containment. So I'm thinking, okay, I got to know something here about cost containment and different types of payers. All right, so okay, new technology and pharmaceutical products have affected the amount and types of services being demanded. Well, yeah, the magic molecules that are coming out of the pharmaceutical industry is certainly impacting our costs. So this one might be true. Okay, so remember, I've got that not there. So that means that because this is one of the reasons, I'm going to say it's false to the not. Okay, I've got to flip it around backwards. Increased payments as a result of physician and hospitals' ability to consolidate and mobilize negotiation leverage. Well, that's probably the biggest thing that's been cutting back on managed care, their ability to limit their payments. So that one is a reason. Therefore, with our negative question, it's a false. Okay. Consumer and provider dissatisfaction forcing government intervention in managed care. Well, any willing provider requiring a greater number of providers being able to be primary care providers, managed care, all those other things, absolutely. Those are things that came out of dissatisfaction with managed care, and we got laws passed that limited managed care's ability to control their market. So again, that one is a reason, and therefore it's false under the negative. So I've got a false, false, false. I don't know why we keep getting D's. That's weird. But we have D here, so I'm hoping it's true. The Affordable Care Act has banned PPOs and HMOs. No, not at all. We know that is definitely not the case. And if you don't believe me, look at the Covered California or other website to look at what's available under the ACA. There are definitely lots of PPOs and HMOs. So this is not one of the reasons they've lost traction. And therefore, D is the only true answer. And I'm going to go with D.
D again.
D again. Now, Lauren said talking it through out loud may take longer, and she could be right. But in my brain walk, inside my brain, I am actually going to look at the question and I'm going to think about it all that way. So I'm not going to say it out loud because that'll make people in the test center mad. But I am going to talk it through inside my brain to convince myself which one is right and wrong, and to include the magic word because. Why do I think this one is wrong? What do I know that tells me something is right or something is wrong? And by doing the four multiple choices, what I'm really doing is eliminating wrong ones. And therefore, I want to make sure I know why I'm saying it's wrong. And by the way, if you could only eliminate two and you have no idea which of the other two is right, then you're flipping a coin. 50-50 is better than 1 out of 4 if you have to guess. Okay? It just is. And you're not going to know everything. There's going to be some that you're guessing, but the more choices you can eliminate, the better your odds. Let's go to number 4.
All right. How is ambulatory care delivered? Option A is medical staff membership, which I feel like I can say is not the answer because it doesn't answer the question at all. B is patient preferences, which again doesn't seem to connect with the question being asked. C and D are both long. So C is in community-based settings ranging from home to physician offices to clinic-based settings or in outpatient or emergency departments of hospitals. So to me, that does seem correct to where ambulatory care is delivered. So I'm going to put true with an asterisk at the end because I want to look at my last option just to be sure that option D isn't more correct. So option D is in community-based settings ranging from home to acute care facilities to clinic-based settings or inpatient or emergency departments of hospitals. So D is false because D talks about inpatient departments and ambulatory care is walking in and walking out, which would be outpatient, not inpatient. So my most correct, most true answer would be C.
See, it is.
And for a lot of these questions, you're going to notice that if you know some of the foundational vocabulary of the questions that they're asking, if you understand even vaguely that capitation is per member per month, or ambulatory is walking in and walking out, even if you don't know all of the nuances of those areas of healthcare knowledge, if you have a rough idea of these foundational terms, when you're walking through, it's a lot easier to eliminate some of the distracting answer options.
Okay, the costs of graduate medical education, GME, are of concern to government policymakers because. So what do I know about graduate medical education? Honestly, not a hell of a lot. Okay, so this is one I may have to struggle with to answer. And I'm going to look for, so we're looking at costs and we're looking at concern to government policymakers. And that actually helps me because now I know that I'm looking for something with public spending, probably, right? If the costs are a concern to government, I've probably got government spending here. And that's going to help me interpret the choices. So the number of residencies and residents are not centrally controlled. Maybe. I mean, does that mean that if it's not centrally controlled, then demand can be higher than it otherwise would, and that would increase costs? So yeah, I'm gonna put the asterisk there. I'm gonna come back to that one. That's a possible yes. The number of medical school graduates exceeds the number of residency positions. Okay, now that could be a concern to government policymakers, but not so much on cost. If we've got a number of positions there, that's what we're paying for. That's not going to increase costs. It's potentially going to hurt access, but not cost. So I'm going to say B's false. Managed care organizations are relatively uninvolved in the payment of GME. I mean, managed care organizations, closed panel ones like Kaiser certainly do have residents. Are they paying for it though? Well, if they are, that's probably less of a public policy concern, more of a payment concern generally. Yeah, it doesn't seem like that's making sense, I think. Many resident positions are filled by foreign medical graduates. Again, that's maybe an access issue, but it's not a cost issue. So I've got A, I think is true. B is false. C, I think is false, but I really honestly don't know as much, so I'm thinking it's false. And D is false. So I'm down to A and C as my two choices because B and D are definitely wrong. And A seems more likely to be right than C, even though I don't really know for sure. So I'm going to put down A as my answer. Saved.
I wish I had this question because I talk about GME all the time. The reason why the number of residency and residents not being controlled matters to the government is because Medicare actually pays direct and indirect cost for resident training. So the federal government is one of the largest payers for GME. And not having control over how many residents exist means that they can't control how much they're spending on that. The more you know.
You must work for like a physician group or something, you know? Yeah.
Almost like I do.
Yeah. Well, you can have number 6 then.
All right.
Yeah.
Which of the following is a unit of measure commonly used to determine physicians' clinical productivity? In healthcare, we love us some acronyms. Oh, somebody's in the chat already putting in guesses. So
She didn't have time to do it quickly. She jumped too quickly on the answer, I think. Slow down.
So answer A is RVU. When I see acronyms, I always try to remember what they are. So RVU is relative value unit, I believe. B would be, which RVU I know is a unit associated with productivity, so that could be true. CMS is the acronym for the Center for Medicare and Medicaid Services. Not so much a measure of productivity, more an organization. IPA could be a lovely beer or an independent physician association, which seems more accurate for the context of this exam. Those are not measures of productivity. That is a physician group. And then CPU is a computer processing unit, which is how computers are productive, but not so much clinical providers. So I'm going to say that because B, C, and D are acronyms that aren't tied to productivity, I can say that they're false and that A is correct.
And I'll point out Christina was correct, even though she answered very quickly, but she did get the right answer.
She did.
And sometimes you just know it and you can do it. Yeah.
Oh, hit the wrong button.
Okay, what population demographic factor is currently having the greatest impact on healthcare organizations? So I'm looking for demographics impacting healthcare, and greatest impact is going to tell me that all of these potentially are right answers, and I'm going to have to use judgment to say which one has the greatest impact. Well, one of the things I'm going to concentrate on is population demographic factor, because that means that if one of my options is not a population demographic factor, it may not apply at all, and I could probably get rid of it. So ethnic composition, well, that is certainly a demographic factor. Is it having a great impact on healthcare organizations? It is certainly having an impact, and it gets into access and payment systems, but is it the greatest? We'll find out. But it's up there as a possible. Insurance coverage, well, that has more of an impact than anything else, but is it a population demographic factor? I don't believe so. So I'm going to say that's false. Geographic distribution. Again, we've got some access issues. We're seeing a lot of that with maternity units right now shutting down. But is that demographic? Not really. So I'm going to say that's false. So I've got A maybe, B false, C false, D. Now age is definitely demographics. Right? So I'm not going to eliminate it. So the question is, between A and D, which one is having the greatest impact? Well, being one of those aging type people, I suspect that it's going to have a greater impact on my need to demand healthcare in coming years. And we're seeing a change and age more than we're seeing changes in ethnic composition, although, that's different for different communities. But D seems like it's a stronger argument for having the greatest impact than A. So a couple people put D in the chat, and I'm going to agree with them, and I'm going to put D as well.
Okay. Public reporting of outcomes information has become a high priority for healthcare payers because. All right. A, measurement of performance have now become well-established, standardized, and accepted by all parties. Well, based on the context of where I work and what I do in my work, where we are in frequent arguments with hospitals about how to appropriately measure different performance measures of care, I'm going to say that we have not yet standardized measurement for all measures of performance. So my gut says that A is false.
And definitely they're not accepted by all parties.
Oh, no. No. Hospitals think one thing, providers think something else, patients that know about these measures think something entirely different. So A feels false to me. B, purchasers are pressuring for disclosure of meaningful performance information for use by buyers and consumers. Okay. That feels maybe true to me. Nothing about that stands out as false. I think there is pressure in the market for publication of data. So we'll put an asterisk next to B for now. C, consumers in healthcare are now well organized, and managed care organizations feel a need to satisfy them. I'm going to say false. Just on the consumers in healthcare are now well organized. There are still a lot of consumers that don't know what data is available to them and don't understand the data that they have. So I think C is false. And then D, physicians are increasingly encouraging their patients to evaluate insurance plans based on publicly reported data. I have never once had a physician talk to me about my insurance plan in that context. So that feels false to me. I feel like if my physician were going to talk to me about insurance, their priority would not be publicly reported data, but coverage. So I'm going to say that my asterisk on B means that it's true, while A, C, and D are false. So B is my final answer.
B it is.
Could you go back on that one, Ryan?
Sure.
One of the things, no, backwards. You just gave us an answer on 9.
Oh,
there we
sorry
go.
about that.
That's fine. One of the things that I had to think about with this one is that it's talking about a high priority for healthcare payer. So when I think payer, I'm thinking insurance. But B talked about purchasers. So who is the purchaser? My first thought was, wait a minute. No, why would purchasers become a high priority for payers? And I said, no, wait a minute. The purchaser is the sponsor of the plan. It's the employer who's buying the plan from the insurance company. So that one took me a minute to work out the definition to make sure I was really answering it correctly.
I feel like that's how they refer to them in law occasionally, which is what I do with my free time. So I think to me that was kind of second nature, but I can see how that might be a confusing thing that would need clarification.
You got to look at the words and ask yourself what they mean, and don't You know, don't jump into it. Again, you got plenty of time to think about it, so use it. All right, let's go to 9, which you already gave us the answer to.
Just trying to keep your streak going.
Oh, you know, hey, we're on a roll here. Health savings accounts were established by what law? Okay, now I have to know something about health and savings accounts, but I have to know which law. This is the type, either you know it or you don't know it, right? So sometimes you can eliminate stuff, sometimes you can't, right? So sometimes you're going to guess. So Consolidated Omnibus Budget Reconciliation Act, COBRA. Well, one thing we know about COBRA is well, I know it, because I teach health law, is it included EMTALA. So that's on HSAs, but Consolidated Omnibus means it included a bunch of stuff. So I have no idea. It might be A. Medicare Prescription Drug Improvement and Modernization Act, that was Part D Medicare. But again, I think it included some other stuff. So I don't know that one either. I'm going to hold on that. Health Insurance Portability and Accountability Act, HIPAA. No, I know for sure HSAs weren't under there. I know they weren't under the ADA. So I've got basically where I'm going to flip a coin between A and B here. And I honestly don't know the answer, but it seems like B. Now, A is an older law, B is more current. HSAs are probably more current than, you know, when was Cobra? Cobra was like back in the 80s, I think, and Medicare Part D came in during early 2000s. So I think B, but this is guessing. This is pure guessing, but I've got it down to 50-50, and 50-50 is better than 1 out of 4. So I've got a better chance now of my guess being correct. So even without Ryan having showed me that it was B, it was.
All right. The demand for nursing care is a function of 2 elements. I like these kinds of questions because you get to think about the relationships between how things interact in healthcare. So answer A is the number of patients and the physicians on staff. And my gut says number of patients seems accurate. And I could see an argument being made for, sorry about my dog. I could see an argument being made for physicians on staff. If you have a lot of physicians, that might change the demand for nursing care. So I put a hold on this till I see what my other options are. B, the number of patients and how sick they are. Okay, well, that one seems a lot more straightforward than the number of physicians on staff. I don't have to draw as many lines. That relationship seems a lot more direct. So B feels more true than A. A still has my asterisk. C, the number of physicians on staff and their specialties. I'm gonna say that that doesn't necessarily impact the demand for nursing care. You would imagine that it has less of an impact, at least, than the number of patients. And then D, the number of PHO and HMO contracts. I mean, again, I think you could make a long-winded explanation about how the number of contracts impacts the number of patients. But like Rick mentioned way back at the beginning of this session, we're really looking for the most correct answer. Which in this case to me feels like what is the most direct connection between 2 elements, and which actually is a really great point. I could argue that C and D are really only one element. So I'm going to say B, the number of patients and how sick they are has an impact on the demand for nursing care.
We did have some thoughts in the chat as well,
Yeah.
about, patient volumes, determining nurse and physician ratio, as well as few of them seeming true, but the question does not ask specifically which
Even
is more true. So that can get kind of confusing sometimes too.
my rule of thumb is even if they don't explicitly say which is the most true, that's almost always what they are looking for. They're looking for which of these is the most correct response to the question that we're asking you. So it's one of those unspoken things, I feel like.
I could come up with an argument for each of them. Number of physicians and their specialties. Well, the more physicians means the more patients being admitted, and some specialties are more nursing intense than others, so you might want those. So I could make an argument for that. The number of PHO and HMO contracts. Well, the more contracts means more patients, so that's going to increase demand for nursing. So I can come up with a feasible argument for each of them, but the most direct, as Lauren says, the most direct answer that I don't have to go around with is going to be volume and acuity, and that's going to be B. Oh, this one's mine. Okay, what is the order of the healthcare continuum? And this, by the way, is a good study question, because as the healthcare section, it's got more questions than any of the other 9 areas, but it's also the most broad, and it's the hardest one to get your head wrapped around because it's got so many things: types of organizations, types of payers, types of healthcare providers. It's got lots and lots of stuff. So if you think about it as the continuum of care, that gives you a way to kind of build a framework that you can then attach things to. So the order of healthcare continuum might be something like, the lowest level to the highest level. It probably is. So you think about a patient going through, right? So I'm thinking about a patient going through the system, and the problem is I don't know if it's forward or backward. It's probably forward, but let's see. So long-term care, then acute care. Yeah, you could go from acute into long-term, but palliative, no, palliative is more going to be at the very end. So A is going to be wrong. Pediatric, well, that's not part of the continuum because pediatric is everything. So even without looking at the rest, I don't think pediatric is going to be right. And medical and surgical are really not part of the continuum either. They're just types of care. That's all kind of just lumping stuff in. Primary care, then acute care, then long-term, then palliative. Okay, so you go to your doctor admits you to the hospital. At the end, you get discharged, you go to long-term care, and we're just keeping you comfortable until you die. That's being called transfer to the internal care unit. C looks right. C looks true. Okay. Then acute care, surgical, palliative, long-term care. Well, again, surgical is a service. It's not really a part of the continuum. And if you're in palliative care, you're not going to go to long-term care after, you're going to go before. So I could eliminate D. So I'm going to go with C because I can find problems with all the others that I don't see any problems with C. So I'm going to go with C.
Looks like in the chat, everyone's agreeing with C. And it's C.
We have a really smart group of people taking this class. And you could tell that because they were agreeing with me. So, sign of really smart people.
All right. Your board of trustees has voted to terminate the privileges of a physician. Which of the following organizations must you inform? So I feel like for some of you that work with medical staff, this might be an obvious answer. I've never worked at a hospital that had privileges, so this one is going to be a guess for me. But off the top of my looking at the answers, A is the AMA. They're a private organization. I can't imagine we would have to report to them on a physician's losing privileges, so that seems false. Local medical societies are typically a part of the AMA or some other type of private organization, so gonna rule that out. National Practitioner Data Bank feels like it's scratching something in my brain that says this sounds like something I've heard about in this area before. So that seems like it could be true. And then the Joint Commission. And I know Joint Commission does accreditation, but I don't feel like they're particularly involved in physician privileges, so that feels false to me. I'm checking my phone a friend chat, and it seems like everybody is in agreement with C, so C is my final answer.
And it's C.
And, you know, one of the things to think about this is, you know, the word must. Which of the following organizations must you inform? Well, AMA is, yeah, it's a professional association. It's not a regulatory agency, so they can't do musts. Local medical society, same thing. Joint Commission is a quasi-regulatory agency. It's not government, but it's certainly got a lot of power and gets involved in our Medicare approval. But it's not the only accrediting body. It's the biggest one in this country. It's the one we know the most, but it's not the only one. So if you're accredited by someone else, you wouldn't have to tell Joint Commission. So we can eliminate that. National Practitioner Database is a specific federal law that you must let them know if you've terminated privileges.
So even without that knowledge, I managed to true false my way into the right answer.
You did. Okay, this is another one of those, you got to either you know it or you don't know it. So Medicare, you know that it's got 4 parts, A, B, C, D, and we're talking about private health plans. Well, Part A is traditional Medicare, right, where they pay hospitals. Part B is traditional Medicare, where they pay physicians and ancillary services. Part D is an add-on that's drug programs only. So I know those 3 are wrong. So Part C is another name for Medicare Advantage. And you just have to know these 4 parts to know that C is going to be the right answer.
Perfect streak. So quick time check. I think we have about 13 minutes left. Did you want to go to the second slide deck, or you want to recap a little
Does
bit?
anyone have any questions they want first? And then if not, we can do some more of these. Lauren and I are having a good time.
Yeah, I love trivia games.
Hi, can you hear me okay?
Yes.
Oh, hey, good morning, James Berkery. One of the fellows responded, they took about 5 months to prepare for the exam, kind of kicking it off with this series. Is that pretty similar to the other fellows, 5 or 6 months of prep time leading in?
God, mine was a really long time ago. I'm trying to remember. I actually started prepping once and then I didn't do it because I got distracted by some other stuff. And then when I went back to do it, I'm thinking probably 3 or 4 months was probably it, but I don't recall exactly. Somewhere along those lines. And again, I would say look at yourself, don't look at other people, and do that assessment. You know, figure out which areas you're in. James, where do you work?
I work for a provider group in San Francisco.
Okay, so you probably have a good idea on a lot of the healthcare stuff as it relates to providers. Maybe you need to spend some time at hospitals. Depending on your job, you may know all the payer types, you may not. I mean, you got to think about what it is you do day to day that gives you the knowledge versus where do you spend your time. And if you're a good generalist who hits all these 10 areas, which I don't think anyone does, but if you're touching bases in all of them, you may need less time to prep. On the other hand, if you're very specialized, like all you do is HR, God forbid, then you're going to have to spend a lot of time on finance. You're going to have to spend some time on quality, things like that. So I would fight against giving you a specific time only because each person's different. But on the other hand, say 3 to 6 months is probably a reasonable guess for most people.
Great. If I could get another question.
Sure.
Also, I noticed a couple of the examples had capitation in them. I think that's mostly a California phenomenon. Is the exam state or regional centric, or
Yeah, no, that's a
national?
great question. And first of all, I think capitation is not California, although I think California probably has more capitation than many states, Mississippi, for example. Um, but but no, this is a national test, and that's a really important thing because every once in a while you'll get a question, and we'll see some later on in other sessions where California has a very specific law where other states don't. And you may say, oh, I know that law. It impacts me. I work on it. It's going to be the wrong answer. So you have to think nationally. And if there's anyone here from other countries, um, you've got to put yourself in the place of the US, unfortunately, for this test. Someone is asking, are there sample test banks we can use to evaluate? And I would say, sadly, no. ACHE used to have uh, a lot more sample tests. They used to give out practice tests, and they do not anymore. They do some that uh, they uh, when they do the big study thing, the 14-unit one, they do some samples, but I was frustrated by the lack of practice questions. And I'll tell you, I took the BOG about a year after I took the California bar exam. And the bar exam, there are literally thousands, probably tens of thousands of practice questions available. And therefore I was doing, 50 questions a day as practice for months. When I started studying for this, I said, wait a minute, where are all my practice questions? Where are my books of questions? They don't exist the same way. So as Ryan says, we do have an older one that we'll send out at the end. You can find some online, but be really careful of it. There's some people who've done Quizlet stuff, and the ones I've seen are not really high quality questions. They don't really challenge you the same way, and you don't know who made them, so therefore you might question whether the answers are correct or not. Do we have time for a few more? A few more questions?
Hey,
Sure.
sorry, can I jump in?
Sure,
Then one more question if there's still time. The text is pretty big, that well-managed healthcare org book. It's like
Mhm.
400 or 500 pages. Do you recommend sort of working your way through that front to back as a starting point, or sort of taking that evaluation and then leveraging that within the content? Okay.
Yeah, put your time where it's going to get you the biggest value. And if you work day to day in an area, skip that chapter. You don't need it.
Even for the
Great.
sections that you need to work on, I find that it's pretty rare that you need to, for most standardized tests, it's pretty rare that you need to like read in detail every single line. Like I can't, I haven't taken the Board of Governors exam yet, but I can say that when I study for other standardized tests, I like to kind of skim read it first and find the sections of like, oh yeah, I really don't know this, and focus in on those to try and maximize my time spent on the areas that I struggle in the most.
And by the way, the only area the well-managed healthcare organization doesn't address is law. So that's an area you're going to have to, if you need it, you have to look for outside sources. Ethics as well, you really need to look at the ACHE code of ethics and some of the ethical statements they make. And we'll talk about those when we hit those areas, but that is a weakness in that book. Everything else it covers incredibly well. Oh, so we have one another. This is a new question we can answer. Okay, let's try this. Whose turn?
I can go, I
Go
guess.
for it.
A management approach that relies heavily on performance measurement, identification of best practices, and formal process specification. Okay. Once again, this is not my area of expertise. This feels almost quality-esque. Lots of answers in the chat already. So A would be evidence-based management, which from the little I know about it does rely on measurement and identification of best practices. So seems like it could be true. Interdisciplinary plan of care seems more focused on clinical planning than management. So I feel like that's false. Service excellence seems more like a value than a management approach. And point of service approach doesn't really touch on measurement of performance. So I'm going to say A is the correct answer. And the chat agrees.
It is.
Agrees. So
One more question, or do
Sure.
we want to do final thoughts?
Let's do one more and then we'll do final thoughts.
Sounds good.
Lauren should have had this one. Okay, medical care provided on an outpatient basis is called. So again, that's when we looked at before, we talked about ambulatory care where you ambulate, you walk in, you walk out. So it is called. Now, the interesting thing there, the emphasis is this is called. Medical care is called. It's not where it's provided, because it could be provided on an outpatient basis in different areas. So, could it be provided in an urgent care clinic? Yes, but we don't call outpatient urgent care. It's outpatient, includes ambulatory cares and is often overlapping. So that would say, yes, that's probably true. Emergency care, yeah, usually outpatient, but it's not synonymous. We don't call outpatient emergency or emergency outpatient. So that one's false. And Medicare is a payer. It's not a type of thing. It will pay for outpatient care, but it isn't outpatient care. So I've got false, true, false, false, and I'm going to go with B as true.
and the chat agrees.
This is one of those questions that makes you read the whole question to make sure you understand it, because you can glance over that one really quickly, see urgent care and outpatient, and jump to conclusions sometimes.
Yeah. Or emergency care, same thing.
Yeah.
You could say, oh yeah, that's outpatient. Well, but it's not. The word is called, and that's the thing you have to focus on. And it's so easy to leave it off at the end of the sentence. Sorry, Lauren, I interrupted you.
Oh, I was going to say, if you have 6 hours to answer 230 questions, like, you have time. It's okay to slow down and breathe and really look at these questions. You shouldn't be trying to speed through them necessarily. I mean, if there are questions like the ones we talked about, like the Medicare parts or the laws where you just know them, yeah, mark those. It's good job. But for the ones like this where it's not an instinctual, like, yes, this is what it is, it's okay to take a second and just double check that you read it correctly and that you understood each of the answers on their own.
And in 6 hours also, by the way, you have plenty of time if you need to go to the restroom, unlike the bar association or the bar exam where I stopped drinking all liquids 12 hours before to make sure I didn't need to waste time. All right. We're at an hour and a half, so this seems like a good stopping point. Throw it back to Ryan.
Thank you, Rick and Lauren. That was a great session. Any thoughts from the audience? Any final questions about this section or anything we covered today before we adjourn for the weekend?
I wish you all the best of luck. If this session was any example, I feel like you all are going to be very prepared for when you take the exam.
All right, thank you, everyone. We will see you next Saturday.
Bye, everyone.